Before I introduce the speaker, I would want to share with you the fact that Dr. Fuller is associated with the Cyberknife Centers of San Diego. So he's come all the way up from San Diego this evening, and as with many of our speakers that visit us from Los Angeles, he had quite a fight to get up through the traffic for the long trip during commuting hours. And sometimes I think we just have to think a bit and realize how dedicated many of these physicians are to come to our group to enlighten us about new technologies and how to proceed with our problems. And so this is an example of, I think, real dedication to the prostate cancer community. Before I start my introduction, I need to say that the Prostate Forum of Fullerton neither recommends nor endorses the views expressed by our presenters. Neither do we recommend nor endorse the positions or opinions of individual attendees, including those of the individual directors of the Prostate Forum. And I'd also like to direct your attention to our disclaimer shown on the large poster board as a continuing reminder of the position of the Prostate Forum is that we in the Prostate Forum ourselves share information, but not physicians, and we leave that to our speakers to do. We'd also request that you hold your questions until the end of the program, as we are recording the talk on DVD, and it kind of disrupts it. People can't hear the questions on video, and this DVD program is a very important part of our outreach to other prostate cancer survivors in the United States and worldwide. After the talk, we'll have a microphone over here at the side for your questions so we can all hear the questions you have. And if you wish to preserve your privacy, then don't give your name during the question and answer period. Tonight's topic is the use of Cyberknife robotic radiosurgery system in the focal therapy treatment of early and intermediate prostate cancer. And appropriately, our speaker, Dr. Donald Fuller, is leading a study to further evaluate both the outcomes and the quality of life effects of Cyberknife radiotherapy in treating early and intermediate prostate cancer. Dr. Fuller received his medical degree from the University of Washington Medical School in Seattle, and he completed his residency at the LDS Hospital in Salt Lake City, Utah. Since 1998, Dr. Fuller has been associated with the Cyberknife Centers of San Diego. The title of tonight's presentation is Prostate Cancer, Sorting Through the Ever-Enlarging Menu of Treatment Options. Please join me in welcoming Dr. Donald Fuller.
Thank you. Thank you. Thank you, Mr. Leffingwell, for inviting me. I'm always pleased to speak to groups. Is the audio okay? Can you folks hear me just fine? Great. I've actually been with Radiation Medical Group in San Diego since 1988 and with Cyberknife Center since 2006. It's a bit newer technology. So the talk is, again, sorting through the enlarging menu of options, but really with a Cyberknife emphasis, because I think that's what you folks want to hear about. So the talk basically has two components. One is just laying a bit of background, which is maybe the first 30 or 40%, and then roughly the last 50 to 60% or so is more Cyberknife specific talk. I think it's important to lay background, especially for anybody out there that's newly diagnosed. For some of you fellows that have been dealing with this for years, it's probably old hat. But I think out of courtesy to those that are still kind of fresh off the hearing of their diagnosis, they might just appreciate a little bit of background. So that's the way we'll go. And with no further ado, we'll get started. Yeah, good. And I think I'll launch right into, and I think Mr. Leffingwell, or one of the fellows mentioned that there's recently been some controversy about the utility of PSA screening. Should we be screening with PSA? Should we be looking for this disease? That's actually been a raging debate for quite some time, but maybe a fresh point put on this debate by two articles just recently published in the New England Journal that really call into question whether or not screening with PSA-based evaluation improves survival. And unfortunately, the answer in those studies is no. Both studies, one American and one European. The trouble, though, is it still leaves more questions than answers. For one thing, just point out a couple of factors with these studies. Over half of the non-screened patients were actually screened. It seems like you can't prevent some men from running off and getting PSAs even if they're not supposed to. And they didn't really anticipate that when they designed the study. So it's really not a clean comparison because even their non-screened population, a good many of them were screened. And secondly, one of the two studies in question actually did show a statistically significant reduction in prostate cancer death rate. They just didn't show a reduction in the overall death rate. So in a population of men whose average age is to the order of 70, even if you reduce their risk of dying from a force of mortality, which is prostate cancer, you've not affected their death rate from cardiac disease, lung disease, bone marrow issues, strokes, etc. So it's not surprising in this population that even if you reduce the death rate from prostate cancer, you may not have a huge impact on overall survival. Doesn't mean that you shouldn't still look for this disease and treat this disease, because left to its own devices, eventually it does cause pain and suffering and misery and death. And in this country, still 30-something thousand men per year do die of prostate cancer. So we need to remember that. And also, my final point on the New England Journal articles is I think their length of follow-up is still short, in the range of 8 to 10 years. And with this early diagnosis population, it may well be that 15 or 20 years is really when you're going to start seeing major differences emerge. So it's provocative, but it still doesn't answer the question. Off my soapbox about that one. Before we start talking about prostate, just what is it, where is it, what does it do? I think most of us have some idea, but maybe not everybody. So that's where it lives. This is a side view of the male pelvis, and above is the bladder, and behind is the rectum, and then right below are the penile structures. And it's just, God put this thing in a ticklish spot. It's just a man's punishment for misbehaving for his life, I think. And what it does is it produces a component of the seminal fluid. And equally concerning, besides the bladder and the rectum, is the fact that the neurovascular bundle that supplies the male potency function courses right by the lateral edges of the prostate on both sides. So if we do anything to try to destroy the prostate, by golly, we can destroy these nerve bundles, which is a real concern. And I think just across the board, be it surgery or radiation therapy, we're getting better at differentiating those, but sadly we're still not perfect. Another highlight, right below the prostate lives the sphincter mechanism that controls the urinary flow. So these are just some of the relationships we're dealing with when we're tasked to cure this disease and yet leave a reasonable quality of life. Okay, so if we get prostate cancer, what do we do with it? Well, I think first just learn about it. If there's any redeeming feature of this disease, it is that it does not advance quickly. And what this means is a man, at the very least, has the opportunity to do his homework, get his consults, read literature, and just learn about the disease and learn about the treatment options. And, prostate cancer, sometimes we just use the word prostate cancer, but they're not all the same. It's not all that... In this person, it might not be all related to the case in this person. So each individual cancer has its own characteristics. I say not all prostate cancers are created equal. So how do we sort through the good ones from the bad ones? Good cancer is sort of an oxymoron. T-stage, tumor stage. Is it smaller than a peanut or bigger than a bread box? There's a place to start. And just highlighting my own development, my first year of radiation oncology residency was 1985, and this is what we saw, because I'm old enough to have trained before PSA was discovered. So we virtually always saw men with palpable disease, either a T2, which is early palpable, T3, which is moderately advanced palpable, or T4, which is very advanced. Palpable means you can feel it with your finger on the digital rectal exam. What has happened since the PSA screening era has come along is there's been a complete shift. Now I would say something like 97% of the men I see are in one of these two stages, and these are almost exotic species. We still see them, but not that often. That seems like a good thing. Fires, cancers, either one of those two things, I think little is better and big is worse. Second thing we look at, the PSA itself, which by the way means prostate-specific antigen. Two things make it, prostate cancer. If a man is diagnosed with cancer, you can have some moderately accurate capability of forecasting his outcome by his initial PSA level, and it roughly breaks out into 3 levels. Less than 10 is generally considered favorable. Greater than 20 tends to be associated with a more advanced disease or a higher tumor volume, and in between is in between. And then finally, the third major factor we look at is a pathology grading. When I say they're not all created equal, you can also detect that on the biopsy specimen. Some are going to look more aggressive and some are going to look less aggressive. And a pathologist recently deceased named Donald Gleason came up with the Gleason scoring system. And what Dr. Gleason observed is there's typically 2 patterns of cancer cells, and the dominant pattern gets a score of 1 through 5, and the secondary pattern gets a score of 1 through 5. So the total Gleason score then is 2 through 10. The higher the number, the more aggressive the cancer. The lower the number, the more indolent the cancer. That said, it's my opinion that Dr. Gleason's scoring system has been a bit altered over the years, subject to almost what I might call grade inflation. Originally, Dr. Gleason characterized 2s through 4s as favorable, 5s and 6s as intermediate, and 7s and above as aggressive. In the last 5 years, I think I can count 2s through 4s on maybe 2 fingers. They're never diagnosed. What we see currently is 6s, 7s, and 9s. That's basically all that we see. That wasn't how Dr. Gleason really originally designed it, but I don't know, it's probably a HIPAA violation to say anybody other than a 6 or a 7 or a 9 out there? Maybe 1 or 2. Yeah, okay. So how it shakes out is 6 or less is favorable, 7 is intermediate, and 9 is, those are still what we call the bad actors. By contemporary, how most pathologists contemporary grade this disease. So the Gleason scoring has shifted a little bit, in my opinion. In terms of predicting the overall prognosis, you really group these factors: T-stage, PSA, and Gleason score. And if you're at the favorable end of all 3 of those, then you have what we call a favorable prognosis case. If you're treated, you're probably going to have a 90+% chance of being cured, and that's also the same kind of fellow that under certain circumstances may just elect watchful waiting or active surveillance. Intermediate prognosis means you're okay on 2 out of these 3 factors, but you may be adverse on the 3rd. And there's a modest drop-off in their cure rate, but not a huge one. And then unfavorable, you tend to have 2 or 3 unfavorable factors out of 3. And their cure rate drops a bit further. But again, don't buy into that those are incurable. That is also not true. And I think especially the better our surgical and radiotherapeutic and medical treatments get, the less true that's becoming. So these are, the literature varies a bit, but by and large, most favorable prognosis case series, be they radical prostatectomy, external radiation, seed implants, are in the range of 90+% cure rate, some high 90s. Intermediate prognosis, 75 to 80. Some of those, if they're early intermediate, may course up towards 90. And then the unfavorable, roughly about cut it in half. But again, that's still a big difference from 0. Even an unfavorable prognosis prostate cancer beats the dickens out of just the average lung cancer. So it's all sort of relative. And then, anyway, let me go back for one moment. For a fellow with favorable or early intermediate prognosis cases, they by and large are very effectively treated by what we would call monotherapy, meaning just a prostatectomy or just external radiation or just seed implant or just Cyberknife. The further they course into this neighborhood, the more we like to throw multiple modalities at them, perhaps external beam radiation and seed implant, perhaps androgen suppressive therapy and external beam radiation. It tends to be a bit more of a project to cure the more advanced fellows. And medical therapy, at least in my own practice, I tend to prefer its use, meaning androgen suppressive therapy primarily. I tend to prefer that mainly for the very advanced fellows. Across the United States, Lupron and similar drugs are very often given for favorable and intermediate prognosis cases. And I think the evidence that supports that is actually quite weak, if this man is getting a very high-powered contemporary treatment method, local treatment method. So if anybody has an early-stage lesion, like a Gleason 6 and a PSA of 6 and a T1C, which is maybe my average guy, and he's being recommended to have hormonal therapy, I would question that. I would question the necessity of that. And this is primarily talk geared for early-stage patients, as I think was mentioned. And the armamentarium is somewhat increasing. Radical prostatectomy is really not the same animal that it was when I trained. We now have thermal maneuvers, means both heating and freezing. External beam radiotherapy has a long and colorful history. Brachytherapy means radioactive seed implants, or a technique called high-dose rate brachytherapy, and then surgery. I only have one prostatectomy slide. This is the Da Vinci robot. I think the cutest thing here is it has removed the surgeon from the patient. He's no longer operating in the patient. He's sitting there at a computer monitor, which means he and I are now the same guy, because radiation oncologists have always operated that way, and the surgeons have graduated to join us. Enough said. Thermal could mean freezing, in which case probes are placed through the perineum and ice balls form to coincide with the volume of the prostate. And quite the opposite, kind of the newest rage in the thermal world isn't freezing, but heating. You have a focused ultrasound depositing basically discs of very high energy at segments of the prostate, and they step back and forth and attempt to ablate the prostate. And I just point these out as these are interesting. These are really not what I'm here to talk about. Radiotherapy is what I do, and basically everything except for this guy, I've done every single procedure and basically do every single procedure on this list. The concept of external beam radiotherapy, that's sort of the overriding concept. Within that concept, there's 3D conformal. Intensity, IMRT is intensity modulated, which is a more advanced version of 3D conformal. Is anybody confused by the letters a little bit? There's a lot of letters in the radiation world. IGRT simply means IMRT with image guidance, meaning you do something before the treatment to guide the treatment. Protons are their own thing. How many have heard KNX 1070 radio advertised protons? I can't miss them, I think. Varian Rapid Arc just showed up on KNX, which is a different platform entirely. And then brachytherapy means brachy from the Latin or Greek from within, as opposed to tele from a distance, means treating from either radioactive seeds or tubes through which a hot source dwells. And the robotic radiosurgery, aka the Cyberknife, I need to speak to the name for a minute. It's not a knife. It's high-powered external beam radiation is what this thing is. I think the genesis of the name is that the original radiosurgical device was called the Gamma Knife. But it is not a knife. Well, occasionally my patients are confused by that. It's a high-tech radiation method. In terms of just the development of radiotherapy through the years, its development sort of parallels aircraft. The ionizing radiation was discovered roughly at this time, and it's got about a 100-year history, and it's progressed just about similarly. So somebody's Aunt Bessie might have been treated by this method, and that's the kind of the profile of what it does that they have seared in their memory, when in fact now we're treating it with these kind of devices. Just a little historical overview. We used to be limited by burning the skin. The original radiotherapy devices were so low powered you really couldn't give a meaningful deep dose without burning skin. And then along comes cobalt in the 1950s, which can penetrate more deeply. And then the modern linear accelerator, Genesis really 1960s. 2D radiotherapy means just lining up with an X-ray, but you really can't see what you're treating. You have to rely on your own knowledge of anatomy and hope you're hitting the tumor. 3D conformal radiotherapy is really the first version of what I would call contemporary radiotherapy that's in use today. And that means identifying your target by imaging, putting those images in a computer, and designing beams to strike the target. And that's a 1990s phenomenon. And then about a decade later comes IMRT, which is still 3D conformal. It's just intensity modulated radiation therapy, means varying the intensity of the beam across its profile, designed by a computer. And what it simply does is it gives you a better capability to conform the high dose to the target. And again, IGRT is just IMRT, taking the added step before you do your treatment of lining up a diagnostic X-ray versus your therapeutic X-ray and making sure they coincide so that you're delivering the IMRT more accurately. And proton beam radiotherapy, in my opinion, belongs right there with IMRT, neither better nor worse. It's another external beam radiotherapy technique. It may get better at some point, but in my opinion, at this juncture, it's not there and it's not proven to be there. Radioactive seeds is brachytherapy, implanted with an ultrasound probe in the rectum, visualizing the prostate, and then we deposit rows of seeds through the perineum. And by the time you've completed one, this is what you've got. This is one of my own seed implants. This is a palladium seed implant, about 130 seeds. The next evolution of brachytherapy is high-dose rate brachytherapy, which is plastic tubes in the prostate, and it does very nice dose sculpting, but anybody offended by this? I would, if there was another way, I would love to lose that part of it. But on the other hand, these catheters give you a conduit, and then you have a single hot source stepping in and out, and it's under computerized control. And then what your computer can do is create dwell positions to sculpt the dose very accurately around the prostate and put very hot doses in what's called the peripheral zone, and put sparing over the central prostate, which is the urethra. So although it's a bit unpleasant to look at the delivery mechanism, in terms of the radiation dose molding capability, in my opinion, this is state of the art. And it also happens to match these very high doses of radiotherapy with the typical location of the prostate cancer cells. Prostate cancer cells do not scatter randomly through the prostate. They tend to occur in what's known as the peripheral zone, which is a horseshoe-shaped zone of the peripheral prostate. This is the back of the prostate. The rectum is back here. When you do a digital rectal exam, you're feeling this part of the prostate, which is why you pick up a lot of prostate cancers with the DRE, because it just feels the part of the prostate that's typically involved. Now enough with the background, now we're into Cyberknife. So the leap with me is, I think Cyberknife is an HDR delivery platform. I'm just doing it without the HDR. That's kind of my thing. I guess I sort of invented that, and I actually got it published in our main journal, known as the Red Journal, exactly a year ago, April 2008. And maybe this slide wash, I don't know, this slide might lose it a little bit, but what it's meant to illustrate is this is a Cyberknife prostate dose distribution. This is the same exact guy with an HDR dose distribution, and they're pretty close to carbon copies. So if you can remember, I said HDR is a wonderful way to sculpt the dose, but it has that invasive aspect. To me, the epiphany about Cyberknife is it can sculpt the dose the same way, but it's not invasive. And so a little bit more about it. It really is a next-generation device, and maybe the first device that, in my opinion, qualifies as artificial intelligence. It takes the IG concept, stereotactic target localization, but it goes at one better, and that is it continues to update the location all through the treatment. IGRT sets image guides once at the beginning, and then that's it. And if the target moves after that, you're going to miss it a little bit. The Cyberknife is a bit different. It continuously updates the location of the target about every 30 to 60 seconds, and it keeps on readjusting the aiming. And what that translates to is sub-millimeter accuracy in the treatment delivery. And no other radiotherapy device has that level. Typical other radiotherapy devices are in the range of 5 to 10 millimeter accuracy. Because of that, when you're treating with other than Cyberknife, you're pretty well obliged to use a larger margin to encompass the prostate, because it can float around in there. This is what a Cyberknife treatment plan looks like. This is approximately 200 individual beams designed on the computer firing from all manner of different angles, converging on the prostate to create a very conformal, very potent dose. And if you look at how the geometry of the thing, this would be conventional radiotherapy aiming from between 3 and 7 angles. This thing's aiming from about 200. So it gives the computer more parameters to play with to design the dose. So that's kind of big deal number one with this device. And then big deal number two is it has, the eyes in the ceiling, as do IGRT devices. And in this example of a prostate, they're focusing on little gold seeds that are implanted within the prostate. The prostate itself is invisible to these x-rays, so we have to do something to make it visible. And what we do is we plant little gold seeds in there. Same technique I do for brachytherapy. It's just instead of 130 radioactive palladium seeds, it'll be 5 gold seeds. This one has 4, but now I do 5. And then you have the computer demonstrating where the seeds are supposed to be, the x-ray imager tracking where the seeds actually are, and then these images are merged in space, and you get these little millimeter correction instructions. And that process is repeated again and again and again. So you'll have image acquisition, location, fire, new position, image acquisition, localization, and fire, and so it goes until the entire series has been run through. And every one of our cases gets a printout on a graph that shows the movement of the target during the treatment. This was actually prostate cyberknife case number 1, and I've still never seen a slide that illustrates this point better. This man, his prostate abruptly moved 6 millimeters, approximately 40% of the way through his treatment. The Cyberknife image guidance detection system corrected that, put it right back on target, and he finished the remainder of his treatments accurately delivered. My point is, if this had even been contemporary IGRT, you would have set your target here, and it first would have drifted about 3 or 4 or 5 millimeters this way, and then abruptly shot 6 millimeters back that way. So even with contemporary IGRT, the target floats within, and the only way you're really going to adequately treat to compensate for that phenomenon is to put on a bigger margin. So bottom line, once I get through my consult and review all the radiotherapy methods with my patients, at this juncture, and maybe it's because I'm getting a Cyberknife reputation, but I'd say at least half of them are selecting Cyberknife. We do still do IMRT, we still do seed implants, but a lot of my patients really do seem to gravitate toward the Cyberknife. And the remarkable thing about that is there's still really no long-term data. There's some intermediate-term data that are interesting, and I'll show you a little bit of data in a couple of slides. But there's no long-term proof that this thing works. It looks very intriguing, and this point, unfortunately, is jumped upon by insurance companies. And the trends actually seem to be flip-flopping a bit. If I had given this talk a year or 18 months ago, I would have said Medicare was the good guy and private insurance is the bad guy. Now, one by one, it seems like the private insurance companies are starting to cover this. We got a new Medicare carrier September 2nd, 2008 that abruptly withdrew coverage from prostate cyberknife. And now they have put it back on the list if a patient is treated under clinical trial. That's the current position of California's Medicare carrier. By the way, this varies from state to state. You can live on one side of a river and get it, and a different side of the river and not get it. Like the Colorado River, for example. But I think we fixed that. That's a lot of discussion has gone into that, as you might imagine. How we do it ourselves, again, the working concept is Cyberknife is a non-invasive high-dose rate delivery tool. Whoops, sorry. Our goal is to, and this is a published high-dose rate brachytherapy schedule. We are simply using Cyberknife instead of HDR to deliver it. And this is a bit larger picture of our side-by-side comparison. And attention to the fact that the prostate is indicated the margin by the white line. The blue line is what we call our planning target volume, which is just a tiny rind around. And the yellow line is the prescription dose that the Cyberknife can wrap around. And on the right-hand slide, the scallopy, lighter yellow line is what HDR wraps around. So the coverage is plus or minus a millimeter, identical with either one. And within the prostate, they both have the capability of substantially escalating the dose in this so-called horseshoe-shaped peripheral zone. And due to that continuous sub-millimeter accurate automated positional detection and feedback, what the computer is showing you is actually what you're delivering to the patient. It's one thing to make a pretty picture, but if you don't have the ability to track what you're doing, it's fantasy to think that's actually what you're giving to the patient. But if you have a capability to track and correct, then that is what you're giving to the patient. So these two are on a par in terms of accuracy of delivery and dose sculpting capability. One of them's invasive, one's not. This was a side view of the same principle. They're mirror images, but this one's the Cyberknife and this one's the HDR. And the color schemes are the same, so again, the dose wraps around, and there's little tubular underdosage here that I've done on purpose to underdose the urethra a tiny bit. That's what this structure is. And then orange and red are hyperdosage, and again, they look quite comparable regardless of whether we're using this or this to deliver it. How we design it more specifically, we treat early or favorable and intermediate cases. Favorable, we treat prostate with a 2 millimeter margin, a very tight margin. That's my favorite one. The intermediate, which means a fellow with a higher Gleason score or a higher PSA, on the involved side will blow out the margin to 5 millimeters instead of 2 millimeters. And again, you can see you're getting a customized 5 millimeter margin delivered by the yellow line on the right side, which is the bad side. And on the less involved side, we're back down to that 2 millimeter margin. There's one implication of a 2 versus a 5 millimeter margin. 5 millimeters sweeps around and pretty well completely encompasses this neurovascular bundle I showed you folks in one of the early slides. 2 millimeter margin spares the outer aspects of that. Whether that's medically significant or not, I honestly don't know, but theoretically it should be. So, I mean, the earlier the diagnosis, the better. That means I can apply this cute little 2 millimeter margin, maybe do a slightly better job of nerve sparing. The reason I sweep it more widely, if you have a higher Gleason or a higher PSA, you're more likely to be having at least some degree of cells outside the prostate as well as inside the prostate. If it's outside the prostate, doesn't mean it's incurable, by the way. That is not tantamount to metastatic disease. A lot of fellows with minimal disease outside the prostate are still perfectly well curable. But obviously, you've got to get the treatment out there. And unfortunately, the conundrum with potency preservation is the cells break out right where those nerve bundles run by. So that's the tightrope that we walk. Any of us, the surgeon, the radiation oncologist. What are our results? We have actually several clinical trials. This is the original one, what we titled Virtual HDR. This one has 42 patients enrolled. I've treated 104, but they're sort of chopped up. This is the original group, and their PSA response is quite reassuring in that out to 2 years, their median PSA is down to about 0.25. But you can see in the first year, it goes to 1 to 2, and that just kind of hangs there. And then at 18 to 24 months, there seems to be a second, more impressive drop. And this is a lot what the brachytherapy PSA response curves look like as well, and to some degree, external beam radiotherapy. In terms of nadir, if a man naders under 0.5, then that man has a very high chance of being permanently cured. And by 2 years, almost all of our patients are under 0.5, and the few that aren't there are heading there. You can see the longer you follow them, the lower the PSA tends to drop, which is the same exact thing you saw on the prior slide. However, they don't necessarily all drop in a straight line. There's a phenomenon called the PSA bounce, where it's going down and then it can head up again. And here's just 3. In the first 24 patients followed more than 12 months, we saw a bounce of some fashion, 10 of them, about 40%. It isn't bottom line with that one is it isn't rising unless I says it's rising. Also known as all is not what it appears. But these are 2 examples of bounces. So it's going down nicely, and then you can see it heads up a little bit. And then it's falling again. This one was our terrifying case. This fellow is actually a lawyer. Most severe bounce I've seen ever. But, so he starts at about 5, never does get lower than about 3.5, and then shoots back up to almost 8. But now at the last 2 consecutive follow-ups, 5 and then 1.8. So, again, you have to be very skeptical about almost any PSA activity in the first 2 years after radiotherapy. It's a much, much, much more, and that goes with Cyberknife seeds, any of them. Much more cut and dried with radical prostatectomy called either you got PSA or you don't. Normal PSA after radical prostatectomy is 0, period. Radiotherapy, it isn't nearly that straightforward. Why? Because the prostate's never been removed from your body. And temporarily it's inflamed and grumpy and all sorts of stuff. And all that stuff can affect the PSA. Inflamed and grumpy, I don't know if that's a proper medical term. Yeah. It's not a completely morbidity-free procedure. It does have some effect primarily on the urinary tract, again, as do all methods of radiotherapy. And how we can actually plot that quantitatively, International Prostate Symptom Scale, the IPSS score, also known as the AUA score. A perfect urinary function has an AUA score of 0, and a perfectly miserable one's in the 20s to 30s. And our average patient, even before treatment, is up around 10, and that's because I think a lot of our population has some pre-existing elements of benign prostatic hypertrophy. Or maybe their cancer itself is symptomatic. 2 weeks post-Cyberknife, it about doubles. It goes from about 10 to about 20. And then by 4 weeks, it seems already to be about halfway back to baseline, and by 8 weeks, it is back to baseline. And that's a pretty constant pattern from patient to patient. Also, so we really get it really kind of ramps up and ramps down, peaking at about 2 weeks. Also, Flomax. Anybody here heard of Flomax? They advertise the heck out of it on TV. I bet not less than a third of the guys in this room are on that drug. In fact, pre-treatment, 34% of our guys are on that drug. 2 weeks post, 100% of them are, unless they're allergic to it or something, because I put them all on it. And then we start withdrawing it, and by about 2 months, about a third of them are off it, and by 18 months, you're kind of back to baseline. But some of my guys remain on Flomax after this procedure, and also after other flavors of radiotherapy for a good long time. Eventually, it tends to settle, but it can be a bit of time. The next one, sexual function. This is certainly a concern to a lot of our fellows. Our results here look pretty good. It's called the SHIM score, Sexual Health Inventory Maintenance, and it's a 1 through 25 scale. 25 is blue steel, 1 is dead, and in between is in between. And our population before treatment is a 16, so they're not exactly perfect on average. And this is our range. We have the entire range. And then at various intervals after treatment, we're plotting this very carefully on the quality of life study. And it's reasonably reassuring. Overall, the whole population, there's not much change going on out to 2 years. But maybe there is. Another way of interpreting this graph is it drops and then there's recovery. And I see that in individual patients from time to time. It gets a bit worse, a bit worse, a bit worse, and then it seems to recover. That's kind of a quirky dynamic. Undefined. First guy's 5-year anniversary is like last month. And I'm sorry, we're supposed to hold questions till the end, so please resubmit. Even before treatment, if you define potent as a sexual health score of greater than 17, only 50% of our population is potent even before treatment. And about a third of them have a low enough sexual health score that we would call them impotent even before treatment. And then and that's because the median is 70, and there's all sorts of issues going on at the age of 70. It may be working well or it may not, is the bottom line. At 40 or 50, it pretty much is. 70 is kind of either way. For blood pressure meds, diabetes, vascular disease, yada, yada. After treatment, we do tend to see some degradation, and fewer of them are what we call potent out to about a year, and then we seem to be seeing a delayed recovery, such that the final result seems the same as the initial result. And beyond that, in our own hand, is undefined. And ditto impotent, the incidence rises a little bit, and then by 24 months is back where it started. So that tends to imply, at least in some of the cases, temporary insult followed by recovery. The nerve-sparing prostatectomy is another one that has that same type of dynamic, actually. So maybe it acts a little bit on potency like a nerve-sparing prostatectomy. And then we're also evaluating full-scale quality of life, which is urinary, bowel, sexual, and hormonal function. And the results are mostly very reassuring. Urinary tract. We see a temporary dip, and our study really is empowered to detect the biggest dip, which is about 2 weeks out. By 2 months, there's a minor dip. After that, you're right back to baseline. That's reassuring. Bowel function really never does change over the first 18 months of our study. Sexual function, this is asking the potency question a different way, and it shows the exact same trend. 100 is a perfect score on this scale. So again, our patients are somewhat less than perfect, especially in the sexual department, even before we do anything. And they get a bit worse for about a year, and they seem to have recovery by 18 months. So no matter how we measure it, this seems to be the recurring theme that we're seeing so far. Number of patients is still relatively small. This is new technology. Hormonal function is interesting. You know those 200-something beams I showed you? One potentially terrifying aspect is if you're not very diligent in your beam design, someone can shoot right through the testicles. And if that happens, maybe you're inadvertently giving these guys Lupron without giving them Lupron. You just cyberknife their testicles. One way that would show up is diminished hormonal function, and we're just not seeing that. We've seen a potential case of severe testosterone loss in exactly one guy. Summary of the initial patient population, 42 enrolled. Their median follow-up's a year, maximum's 2.5 years. And we got our Cyberknife in July of 2007. So we're just going to start getting some guys 3 years out. None of them have relapsed so far. That's not surprising. It takes this disease 3 or 4 or 5 or 7 years to relapse. And if it relapses sooner than that, it's probably metastatic disease, not local disease. And metastatic disease usually isn't there in the favorable guys in the first place. This is what we're seeing on the PSA. By 1 year, it's gone from 7 down to about 1. It's a little bit better at 1.5 years, and it seems especially impressive at 2 years. And it keeps on dropping in the limited number I have at 2.5 years. A lot of those guys are just flat 0 or 0.1. I only have a handful of those guys so far. Toxicity is obviously a huge concern. Grade 3 is a life-altering toxicity. So far, knock on, we have 0 of those. We have a modest number of bladder and bowel grade 1, 2s. What's a grade 1? Maybe a little bit of bleeding when you pee or when you pass stool. We've seen that in just a couple of bladders and in a couple of rectums. It's not been a major complication in anybody. And it is seen to some degree after any form of radiotherapy. And again, in terms of the overall quality of life scale, temporary decrease in sexual function followed by recovery, and on the rest, and a temporary decrease in bladder function followed by recovery, otherwise holding up very well. That study really paved the way for a larger study, which is a nationwide study sponsored by Accuray, which is the maker of the Cyberknife. And that has participants in a variety of states. And the goal there is much larger, 253 cases, and at last check, we're about a third of the way there. And I am the principal investigator of that study. Our newer clinical trial, and this one's much newer, is Cyberknife for locally recurrent cancer after external beam radiotherapy has been given previously. And that's a difficult situation. Anybody been told can't have further treatment after your radiotherapy? Yeah. And that's by and large true. But except not exactly. We'll come back to the rationale in a second. So the eligibility is history of prior pelvic radiotherapy for prostate cancer, biopsy-confirmed local recurrence of prostate cancer. It has to be at least 2 years since the original radiotherapy course. If it's coming back sooner than that, you probably got metastatic disease. So we're not going to subject you to high risk when you probably already have metastatic disease. This is just the game changer. When you have the capability to wrap a dose with millimeter accuracy around the prostate and wrap it tightly, then that's conventional wisdom may no longer be correct wisdom. And we don't know. It may still be not a terrific idea, but we're doing it. And again, the predicate is HDR brachytherapy. This group is from UC San Francisco, and they published a very, very nice salvage rate with high-dose rate brachytherapy. And again, there's your high-dose rate picture. And this is a Cyberknife picture, basically cloning the same dose distribution. So again, we're applying the HDR concept to Cyberknife, this time as a salvage for local recurrence. We've treated exactly 2 patients on that trial, so there is no information about this one yet. Why might it be a good idea? Well, maybe it'll do the same thing HDR does with less invasive quality. On the other hand, it's never been done, and maybe the complications are just as bad as the conventional wisdom says they're going to be. So we're pretty straightforward about that when we do consults with our patients. But they don't have a lot of other red-hot, terrific options. Prostatectomy's got issues, freezing got issues, heating's got issues. A lot of these guys go straight to hormone treatment, which is okay, but that's not completely a benign intervention for all the guys either. So if this thing works like the HDR and it loses the invasive aspect and the complications are reasonable, we might really have something. We hope. And then a sort of a different way you can take Cyberknife. It's also actually not a bad IGRT delivery method. This dose distribution looks the same. The only difference is this is 28 little treatments instead of 4 big ones. That's more conceptual at this point. The reason that that's not done by and large isn't that the device can't do it, it's the device is not efficient. Treatment times are relatively long, so it's just not practical. But the newer generation Cyberknife actually is getting fast enough that if for whatever medical reason IGRT might be better than these few large ablative doses, we can probably do that too. And then to wrap it up, we're down to the last couple of slides. It also does have applicability for advanced or metastatic cases. This would be a case of a very recalcitrant bone metastasis. It came back after conventional radiation therapy, and we actually blew it to smithereens with a Cyberknife. This is a retired professor with an iliac node metastasis. Again, this came back after external beam, but you can see the mass is outlined by red, and the Cyberknife dose line is outlined by yellow. And terrifying, it's surrounded on 3 sides by small intestine, which you could perfectly well destroy if you're not very careful. This is, again, accurate enough that you can just kind of sneak it in there in cases where, again, previously we really weren't able to give meaningful additional treatment. So we'll call that troubleshooting. Probably our main application by far is the early cases. Sort of the intriguing one in my mind is, does it work for recurrent cases? And then the troubleshooting means relapse after external beam in a node or in a bone. So it does have applicability also toward the advanced end as well as the early end of the spectrum. So just final conclusions, prostate cancer comes in different flavors, and almost always there's more than one way to treat this disease, which I think is both a blessing and a curse. Different people have different goals. Watchful waiting may be just fine for one guy, and a different one says, get that thing out of there. And, you know, you get enough good opinions, and you'll do the right thing. Make the punishment fit the crime. Big cancer, big treatment, little cancer, little treatment or no treatment. Cyberknife does fit well with a potentially significant number of prostate situations, and our data to date look very encouraging. We're very pleased with what we're seeing with the PSA. It rivals any other radiotherapy technique I've seen in 21 years. And the toxicity is not bad at all. Quality of life is good. Potency preservation looks good. One other comment about potency, by the way, it seems biphasic. The men 60 and under seem to have near 100% potency preservation. The few that we have seen lose it tend to be in the 70 to 80 age group. And again, we've seen that with brachytherapy and external beam radiotherapy as well, and I think with radical prostatectomy as well. So age by itself is a pretty powerful factor. So if treatment A has a 90% potency preservation rate and treatment B has a 60% potency preservation rate, it might have nothing to do with the treatment. It might be the treatment A was applied to 55-year-olds and treatment B was applied to 75-year-olds. So you have to be aware of that when you're comparing numbers. And I'm sure I could go on for about 24 hours straight, but I guess we'll call it quits. Thank you.
Okay, I think we'll start the question period here, and I just line up here and we'll just pass the microphone down the row. I might start with one, Dr. Fuller.
Yes, sir.
Certainly appreciate your coming here and giving this excellent talk on this new technology. One of the criticisms that have been made in the screening argument is that we are over-treating people, and particularly the early stage folks.
Right.
And the question is, in your practice, do you have some protocol where you decide where it'd be more appropriate for them to do active surveillance versus treatment?
Absolutely. We'll bring that up as an option in virtually all of them. The ones where I think that actually makes sense is the combination of low-risk patient and relatively limited life expectancy, either a senior man or a sick man. And obviously at the polar opposite is a Gleason 9 T3, or that disease is going to take a man down in 2 or 3 years, so you better do something with it. And in between, you just, it's really, you go through the plus and minus ledger of various radiation approaches, surgical approaches, medical approaches, and watchful waiting. And in my opinion, my role is really educator. I don't tell a man what to do. I just try to educate. And I'll just emphasize this one or that one depending upon the particulars of his case, including watchful waiting. But I think it's a relatively small group that I think that's the best treatment option.
Mm-hmm.
But it's a treatment option for virtually anybody.
The second question is, do you use this at all for focal therapy? And if so, kind of what percentage of your patients do you prescribe that for versus full prostate treatment?
You mean across, I'm sorry, focal therapy?
Focal, just going in, it's like doing a lumpectomy for a breast cancer patient rather than a mastectomy.
Yeah,
I
I get your question.
The cryo people, we had a talk last year of some of them trying that, beginning to try that for prostate cancer.
My issue with that is not so much the technology. If you're a skilled cryotherapist, you can maybe put a nice focal freeze ball. If you're a skilled Cyberknife applicator, you can put a focal hot zone of radiotherapy. That's really not the issue. The issue is the technology to accurately detect the full location doesn't exist. So and Dr. Walsh in particular has demonstrated relatively convincingly that this tends to be a multifocal disease. There may be a dominant lesion that shows up on a biopsy, and that dominant lesion may show up on an MRI or a sophisticated imaging study, but 7 millimeters away is a second smaller focus that's perfectly invisible. And that's your hazard with focal therapies. You're going to be missing those. Now, if the imaging gets better, advances to the point to where we're confident, then I would think about that. And another group I might think about that is in a fellow that's relapsed in the prostate after prior radiotherapy. But that's even further down the road of conceptual with no data. So I think I'm far enough down that road already. That's even one step further.
Okay, thank you.
Okay, thank you.
Doctor, thank you for an excellent presentation here
Thank
today.
you.
Okay. My question has to do about the accuracy. I think you mentioned 1 millimeter.
Correct.
Of being able to deliver the dosage to the targeted area.
Correct.
So could you just explain at a high level the technology that's used to be able to enable that level of accuracy?
Stereotactic localization, input to the computer combined with mechanical accuracy of the device end-to-end is sub-millimeter. The mechanical accuracy is to the order of 0.2 millimeter. There are relatively substantial published data, primarily from Stanford, both in CNS, meaning brain, spine, and prostate, all performing end-to-end measurements that demonstrate that same level.
So how does...
It really has to do with the continuous feedback.
Okay.
Okay? And it's just the resolution is sub-millimeter, the computing capability is sub-millimeter, the mechanical accuracy is sub-millimeter, so end-to-end, the whole process is sub-millimeter.
So this one more question.
Yeah.
How is the movement of the prostate sensed? What is the technology that allows the computer to understand that the prostate has moved?
You've got 5 seeds in a specific geometric pattern, localized from 2 different angles on X-ray. That's called stereotactic.
Okay.
So you'll have an A image and a B image, and there's only one position that will satisfy both those images, and the calculation accuracy is sub-millimeter for localizing that. And the system repeats that acquisition about every 30 seconds.
Thank you.
Okay, thank you.
Relative to that last question, does that imply that there's a high radiative imaging dose going on?
There is an added dose from imaging, but it's trivial compared to the therapeutic dose. It's well under a rad. We're giving 3,800.
For the whole pelvis?
Correct. It's actually, it's less than you think. It's a very low energy X-ray. It's probably barely above dental.
The other question I had was, there seemed to have been a consensus, as I recall reading about it 4 or 5 years ago, in the radiological community, that nadir to be expected for control, future control, was about 0.2.
No, that would come from Dr. Frank Kreitz, I think, in Georgia. That's not consensus, that's Frank Kreitz.
That's his alone?
Yeah, that's not, the Astro definition is 3 consecutive rises, and the new definition is a rise of 2 points off the nadir equals relapse. Neither of those definitions makes any reference to a specific level. That said, our literature is replete with data that the lower the nadir, the less the chance of a subsequent failure. Okay. But there is no all or none, guaranteed cured with 0.2, not cured with 0.3. More likely to be cured with a 0.2 than a 0.3. But there is no absolute magic level where below it you're cured and above it you're not. Okay, Dr. Bagshaw from Stanford, the original external beam guy going clear back to the 70s, had a fascinating population of guys that nadired somewhere between 1 and 2 and stayed there for well over a decade. That's a dozen patients out of his 1,000 at Stanford, but the point is there is no absolute level at which you're cured or not cured. It's just probability. If you get to 0.2, your chance of a cure might be 98%. If you get to 2.0, maybe it's 18%. But in either case, it's not all or none.
Thank you.
Thank you.
Hello, Doctor. I would also like to thank you for a very great presentation. I'm not sure I understood everything completely, but and some of these fellows have asked questions that I had, but let me just possibly reiterate some of those again.
Sure.
I guess I understand that you're not doing any, like you call focal therapy there if you have pretty good evidence of something like from a color Doppler ultrasound of where the tumor is, so that you're doing some sparing of the prostate, or is it total ablation of the prostate?
Probably close to total ablation of the prostate. And again, at 2 years, our median PSA is 0.25 and still falling, so that does tend to imply there's little to no functioning prostate tissue left. It's after conventional external beam that they often nadir around 1 as opposed to 0.1 or 0.2. 0.1, 0.2 nadirs tend to be more typical brachytherapy nadirs, and right now we're seeing brachytherapy-like nadirs with Cyberknife without the long-term confirmation, but we're encouraged by that. But it may be that you kill all the cancer, but you don't completely kill off the prostate. That guy naders at 0.8 or 1 or something like that, and that might be a typical external beam result. And then you do something a little more powerful, like a nice hot seed implant, and that guy naders at 0.1. But in either, whether he had external beam and nadired at 1 or had seeds and nadired at 0.1, the cure rate may not be as different as you think. My sense is brachytherapy and probably also Cyberknife is more of an ablative type procedure. An external beam, conventional, is the one that may a little bit more spare the prostate.
I was also curious as to why you would get to those results with like half of the dosage that they're giving for.
You're not giving half the dosage. Biologically, you're giving more dosage. 38 gray in 4 shots biologically is more powerful, according to our radiobiology calculations, than 8,000 centigrade in 40 shots. The dose per treatment has more influence over the potency than the total dose. A single shot of 2,000 centigrade will kill everything in its wake, by and large. That's the original gamma knife for brain lesions. 1 shot, 2,000 centigrade. Smoldering wasteland inside the target zone. Give that same guy 5,000 centigrade and 25 shots with external beam, it's actually not as ablative, even though the total dose is 2.5 times higher. So there's 2 things to look at. One is total dose, but of even greater importance is dose per treatment. If the dose per treatment is large, its mechanism of action is probably not even the same action. Little doses, everybody's familiar with the double-stranded DNA. Little doses tend to break one of the 2 strands, little individual doses. And then those are very often repaired. You do it enough times, eventually the cell dies. Now, take that same patient, instead of 40 little doses, put 4 big ones. That does double-strand DNA breaks, not single-strand. Those are more uniformly lethal, not repaired. So even at a lower total dose, the effect is more destructive. And that does depend, by the way, on the exact cell type that you're treating. prostate cancer in particular seems uniquely sensitive to a few large doses. Squamous cell carcinoma of the tongue, probably exactly the opposite. So it depends on the cancer type. One is very rapidly growing, one is very slow growing. Slow growing tissue tends to be more damaged by a few big doses, and that's prostate.
Is this procedure also applicable to irradiating like the lymph nodes and things like that for known escaping? Not necessarily to the bones, but it's outside the...
One of the very
capsule.
last slides I showed was a solitary large lymph node metastasis in a prostate cancer case. Yeah, we apply this all over the body. It was originally invented by a neurosurgeon from Stanford and applied for brain lesions. And it is currently applied in greatest number for lung, liver, brain, spine, prostate. And a variety, again, of what I call troubleshooting. And one of its highest and best uses is focal retreatment after failed prior conventional radiation, because it can paint in a much hotter dose with a much sharper margin.
One last question.
Yes, sir.
My wife took a cancer patient over to a facility in Bakersfield, and she just learned about the Cyberknife that they had.
I think they
That
either are
was
just installing it or just about to install it. I don't know if that device is operational yet.
Yes, well, they told her that it would be a week or two, something like that.
Right.
They were to be qualified for prostate cancer, and I didn't know whether that meant that it was FDA approval that they got to. Oh, Medicare.
Yeah, Medicare has been a real saga. Again, it was approved across the board until September 2nd, 2008. September 3rd, 2008, we got a new Medicare carrier, not approved for anybody. Actually, paradoxically, the one group it is approved for is that last protocol I showed you, the retreatment of failed external beam. They did approve it for that, but nothing else. And now with some relatively intense ongoing discussion, their most current position is they approve it as long as you're treated per clinicaltrials.gov registered clinical trial, which is our clinical trial. To my knowledge, Bakersfield doesn't have that trial. They're not on my trial. There are 2 trials in the U.S. Perhaps they're on the other one. But right now in California, unless you're enrolled in a clinical trial, it's not covered.
Thank you, Doctor.
Thank you.
Okay, thank you, Dr. Fuller. I had
you.
a couple questions.
Yes.
One is, could you describe what a normal length of treatment would be for someone for treating their prostate?
Yeah, each individual treatment's about an hour,
And how many treatments?
4 in a row.
Just 4 treatments.
Start Monday, finish Thursday is our typical regimen.
So it only lasts 4 days?
Correct.
Oh, okay. And could you describe the...
That's one of the 2 main hookers with this. The other one is the technical sophistication. So there's sort of 2 reasons people are drawn to it. One is 2 months down to 1
Well,
week.
that's a lot shorter treatment than typical IMRT or something.
Yeah, it's not IMRT. Again, it's much more like HDR brachytherapy, in my opinion, than it's like IMRT.
And the other thing, could you describe the size of the beam that you use?
There's 12 different beams we have to select from, and they're selected by the computer. And the smallest is 5 millimeters, and the largest is 6 centimeters.
So
We let the
what
computer
the computer controls the size of the beam?
And aiming direction and position from which it's fired. So the computer controls a whole bunch of parameters.
How about intensity?
Yeah, that too.
That too?
Yep.
Yeah. Okay, and
So if the computer finds a position that it likes, it may shoot a big beam from that angle. If it finds another position that it sort of likes, it might shoot a half beam, and it may go through another position and not shoot from that position at all, because maybe all it sees is bladder and rectum.
and it may change the length of time it's on a particular point? as
Well, yeah, it varies the dose. I mean, it can be anywhere from a fraction of a rad to 100 rads from a single shot. And it strictly depends on what it's seeing in terms of what's called the beam's eye view. If it sees nothing but target, it's going to shoot a big dose. If it sees nothing but normal tissue, it's going to shoot 0 dose, and in between is in between.
And how do
That's
you...
really the IMRT concept. And this really does, in that way, Cyberknife is IMRT. We're just applying it with a more brachytherapy-like mentality and biology.
And how do you plan the treatment strategy for an individual?
The first thing you do is you plant the 5 gold seeds, and then a week later you take the patient and you give him a prostate CT, or a pelvic CT scan and a prostate MRI scan and merge those in space. And I think I heard somebody mention color Doppler. We also have a technology called dynamic perfusion MRI that is a lot like color Doppler. So the MRI, I think, gives more information about the size of the prostate and the shape of the prostate and the location of the cancer, but the computer needs the CT to do the proper radiation calculations. So the best way to plan it is to take both of those. And you can use the seeds as a registration point and register seed to seed, 5 seeds over 5 seeds. And again, they're registered with millimeter accuracy. And then you use the MRI to design the prostate. The computer pretty much uses the CT to calculate the beam intensity.
So does the computer do the programming for the exact treatment, or do you have a physicist that does that?
Yeah, I design the target volume and all the normal structures, and then the physicist is really the one that designs the dose distribution. So it's really a collaborative effort. As it is with, and that's pretty much the drill with any flavor of radiation, be it proton, IMRT, 3D seeds.
Okay, thank you
I'm
very
sort of
much.
a transitional figure. I actually do a lot of what the physicist does, but
Well, I'm
typically
sure
it's
you work
MD,
together.
PhD.
Okay, thank you.
Sure.
Before we adjourn, I'd like to present Dr. Fuller with our Speaker's Cup in appreciation of his fine lecture.
Oh, thank you. Thank you. Thank you. Thank you for inviting me. Good, good.